the Indian burden of diabetes and hypertension, the 10 critical questions. Half a century ago, most clinicians believed that the rise in systolic BP level with advancing age was a benign and a physiological response to age-related arterial stiffening. So they never thought that increase in the systolic blood pressure is a pathological one or a malignant one. They thought that it is only benign and physiological, no need of any treatment. Systolic BP was believed to be normal as long as it didn't exceed 100 plus your age. So for example, a 70-year-old woman with a systolic BP of 170 didn't need any treatment because 100 plus 70 is 170. But now more than 140 we have to treat it. See, this is an editorial way back in 1935 in BMJ. He said that the greatest danger to the man with high BP lies in its discovery, because then some fool will try to reduce it. So the impression is that don't very high blood pressure, including the Churchill, a president of US, he died with a blood pressure of more than 300 by 150. See, 2 millimeters of mercury decrease in the mean systolic blood pressure. So there will be a 7% reduction in the risk of ischemic heart disease mortality and 10% risk in the reduction in the risk of the stroke mortality. So we have to reduce the blood pressure as low as possible. Even the 2 mm is also good as far as the reduction in the ischemic heart disease and the strokes are concerned. So this is the impression from the Lancet 2002. This is the recent study done by ICMR and India study, the prevalence of the lifestyle diseases in India in the form of the diabetes, hypertension, obesity and dyslipidemia, that means metabolic syndrome. So this study was done by Dr. Mohan et al. From Chennai. So they have studied almost all the states in the India. So finally the impression is diabetes at a rate of 11.4% in Indian population, and then pre-diabetes about the 15.3%, and 35.5% people have hypertension, 81% have dyslipidemia, 28.6% have generalized obesity, and 39.5% have the abdominal adiposity. So that is more dangerous also. If you see these numbers, they are very, very high in number. And as far as the diabetes is concerned and the pre-diabetes is concerned, nearly 25% of the Indians are having either the diabetic or pre-diabetic, and 35% are the hypertensives. So what is the hypertension in Indian population? Because the prevalence is very high. 1 in 3 people are hypertensive in India. About 72% of the patients, they do not have their BP under control. So the poor control because of the undiagnosed blood pressure or asymptomatic nature of the blood pressure is one reason for not getting the treatment. And even people are under treatment, they are not under control because they are not achieving the targets. More younger population is getting hypertensive. Most of them also have their killer twin, that is diabetes, because diabetes and hypertension is a deadly duo in most of the Indian population. And target organ damage is seen in the early years of the hypertension, even in the younger population. So nowadays we see a lot of the people with young strokes or young myocardial infarctions, even in the less than the 30 years or less than the 40 years, we are seeing a lot of the people because of the target organ damage. The same thing happens to the CKD also. So what are the challenges in the diabetic hypertension in Indian people? Increasing and concerning number of the uncontrolled hypertensives in the diabetic population. So most of the diabetics in India and also the hypertension in India, even though they know that they are living with the diabetes and hypertension, but they are not achieving their target levels of the blood pressure less than 120/80 or the HbA1c less than 6.5. Many not aware of their hypertensive status because in asymptomatic nature, may not receive the correct therapies, and many not controlled also. So I told you that the diagnosis is very few, the people on treatment is also very few, and the people who are on targets is also very, very few. More and more younger patients being diagnosed and at risk because of their environmental factors. The sympathetic overactivity seen in the younger hypertensive patients. Salt sensitivity, that is again another important point, especially in the South Indian dishes. So a lot of the salt being used in the cooking processes, that worsens the hypertensive outcomes. And physician inertia, nowadays we are not seeing much physician inertia because our continuous educational programs, we are all aware of the diabetes, hypertension, etc. But there are some patients' myths and the misconceptions about the management of the diabetes and hypertension. But this physician inertia is also one of the things for the poor management of the diabetic hypertension with multiple drugs and the combination therapy. So these are the progressive diseases we have to uptitrate the treatment. That is the physician inertia. And the non-adherence to the drugs along with the unsuitable lifestyle among the patients is also very, very common, because most of the drugs, these people, they don't take it because for the fear of the side effects. For example, if the patient is on amlodipine, if they get the fatal edema, they stop taking the amlodipine. So such things are there. So we have to tell the possible side effects of these drugs so that the adherence will be improved. If you see the excuse me.
Right, sir.
Nearly the 5,000 patients with the diabetes, more than nearly the 60% of them were reported to have the hypertension. So this is the epidemic, twin epidemic study. So the most of the people with the hypertension, they also have the diabetes. On the other hand, most of the people with the diabetes, they also have an added hypertension, and finally both will be positive in most of the individuals. Here it says that hypertension with the diabetes end organ damage. If you see here, the end organ damage, it will be more when the people are having both the combination of the diabetes and hypertension. So next question number 3. What are the BP targets in the diabetic hypertension? See, the BP control targets in the diabetic patients, what do the major trials have to say? A lot of the trials are there. So these are the UK PDS, you know that, done in UK between 77 and 97. And hypertension on the target trial is a HEART trial, an advanced trial, ABCD trial, ACCORD trial, SPRINT trial. So all these trials, they say that the reduction in the strokes, reduction in the IHD, reduction in the CKD, etc. will be seen provided if you control the blood pressure very effectively and if you reduce the systolic and the diastolic blood pressures very effectively. So there is no doubt that hypertension has to be treated very aggressively and very efficiently to avoid the target organ damage. The question number 4. What is the risk that both the hypertension and diabetes pose to the patient? See, the morbidity and the mortality along the renal continuum, diabetes and hypertension are the killers of the kidney. See, if you see the risk factors for the diabetes and hypertension are the same environmental factors like physical inactivity, obesity, high calorie diet, etc. And they lead to the endothelial dysfunction because of the nitric oxide deprivation, and then the microalbuminuria, then the macroalbuminuria, then the nephrotic proteinuria, that means masoproteinuria, and finally elevation of the urea and the creatinine, and slowly CKD, and then finally CKD stage 5 is the end-stage renal disease and the death. See, if you see these features, both the cardiac as well as the renal are commonly involved in uncontrolled diabetic and hypertension population. So we need to give a good cardio-renal protection in all the people with the diabetes and hypertension. See, the presence of both the diabetes and hypertension, the risk of the cardiovascular disease increases by 75%. See, CVD, that is the reason, the cause of the death in diabetes is a cardiovascular disease. The cause of the death in hypertension is again a cardiovascular disease. The cause of the death in both is again a cardiovascular disease. So, all the people of the diabetic and hypertension, we need to see that the cardiac protection must be there. Along with the cardiac protection, you should also give a renal protection. It doubles the risk of the renal damage and hastens the ESRD because hypertension could be a cause and effect of the renal failure. So uncontrolled hypertension will lead to the CKD, and the presence of the CKD will make the blood pressure will double up, so that causes the hypertension. So both are the vicious twins, two of the most highly prevalent diseases in India. Question number 5. Why are early renoprotective strategies needed in the diabetic hypertension population? See the young Indian hypertensive patient journey. See, if you see this undetected diabetes, undetected hypertension, and ignorance, 42% of the Indians at risk of misdiagnosis of the hypertension. See, they don't record the blood pressure at all. So the opportunity screening always is ideal because the universal screening is not possible in a country like India. But whenever a fellow comes to any department, so at least check the blood pressure and say whether the patient is a normotensive or above the normal blood pressure or in the hypertensive range group. So by this time you know that the normal blood pressure, pre-hypertensive blood pressure, stage 1, stage 2, stage 3. So if you name them, which stage of the hypertension the people are having it, when they are the normotensive, still if the patient is at high risk of getting the hypertension, so a salt deprivation or good sleep, some yoga, some meditation, some dietary approach, so these are all very much needed to postpone the onset of the hypertension in a high risk individuals. See, the Indian hypertension prevalence, already I told you nearly the 40%, 30 to 46%, the newly detected hypertension. So slowly, if you neglect the risk factors, and definitely the hypertension remains uncontrolled and finally leads to the cardiac complications, renal complications, and ESRD or IHD or heart failure or CVA or peripheral vascular disease or aneurysms. So these are all the different complications we often see in our population just because of the uncontrolled hypertension and cardiorenal complications. See the scenario of the renal replacement therapies in India. Why early intervention with the renoprotective drugs is needed. So you all know that the dialysis or the renal transplantation, these two are the final stages. See the treatment of the choices for the end stage renal diseases. You all know what is the cost of the dialysis or the renal transplantation, how difficult it is in Indian population. So the most important is the prevention is better than the cure. So kidney transplant costs anywhere between 50,000 to the 3 lakhs, and over 90% of the patients requiring dialysis or transplantation in India die because of the inability to afford the care, and majority of the patients die even before reaching the end stage CKD. But thanks to the governments with the Arogyasri or some central government schemes, a lot of the people are now they are getting the dialysis free of the cost, and they are living for a longer period. But one thing is very clear: once the patient is in the CKD, definitely the quality of the life will be reduced drastically. Even though the length of the life period may be increased, but the quality is not improved in most of the CKD population. Question number 6. What do guidelines mention to diagnose the diabetic hypertension early? See, these are the different things there. European Society of the Hypertension 2023, characteristics of the most frequent markers of the hypertension mediated organ damage in hypertension. See, you have the LVH, so that can be detected by the 3 ways. One is the ECG, most important and very common, and then the echo. Nowadays echo is also very common investigation. So it's just extension of our stethoscope or our ECG, and then some people know they get the LVH by the MRI. And the GFR is very important after you knowing the creatinine. So don't be happy with the creatinine alone, but GFR is very important. And urinary albumin creatinine ratio is also very important. Spot test, urine examination, and carotid intima-media thickness is important. Ankle brachial index or retina examination for your retinopathy, whether maybe the hypertensive retinopathy or a diabetic retinopathy. See, these are all the different parameters by which you can tell that these target organs are damaged or not, that the heart is damaged or brain is damaged or the kidney is at risk. So we know that by noting all these things. So just recording of the blood pressure and just getting the fasting and the PP blood sugars is not sufficient in a twin epidemic of the diabetes and hypertension. So the chronic population, those who are at the risk, so definitely we have to see whether the target organ damage is there or not, so that we can give the good protections. The diagnosis of the early target organ damage. So the left ventricular hypertrophy, you know the criteria that, and then the ECG, left ventricular hypertrophy, again you have a criteria, ultrasound examination, pulse wave velocity, ankle brachial index, serum creatinine. So these are all the things are there to know whether the patient is a target organ damage or not. And question number 7. Lifestyle modification in the Indian diabetic hypertension. These are the very, very important very cheap and very long lasting. So whether the patient is on any number of the treatment drugs, so definitely their lifestyle modifications help them to stay for a longer period without any complications. See, these are all the risk factors, the family history, and then the inactive lifestyles, sleep deprivation, overweight, and you have the signs of the diabetes like blurring vision, increased thirst, etc. And lifestyle tips: avoid the refined carbohydrates. So advise the complex carbohydrates. So the more the starch, not your simple sucrose or the fructose or your glucose. Cut back on the sugar. That is very, very important. Drink less alcohol. Eat healthier foods like green leafy vegetables, pulses, legumes, high fiber diet, low salt. Get sufficient sleep, at least 6 to 7 hours a day. Keep an active lifestyle. So physical activity is very, very important, and reduce the portion size of the food. So these are very important. So impact of the lifestyle modifications on the blood pressure. See the weight loss. So the target BMI, if it's 18.5 to, for our population, Indian population is 23. Beyond the 23, we consider them as overweight. And if you reduce the weight loss, at least 1 kg weight loss will reduce the blood pressure by 1 to 2 millimeters of the mercury. The DASH diet, there is a dietary approach to stop the hypertension. So the food contains more fruits, more vegetables, and low fat dairy. So reduces the blood pressure by 8 to 14 millimeters of mercury. Sodium intake, salt reduction. So definitely will reduce the blood pressure by 2 to 8 millimeters of mercury. And moderation of the alcohol, so reduces the blood pressure by 4 millimeters. It's a U-shaped. The more the alcohol, more the blood pressure. But moderation of the alcohol will definitely reduce the anxiety and the tension and reduces the blood pressure. Exercises, both the aerobic exercise, like simple walking, jogging, and swimming. So they are all very useful, and isometric exercise, etc. So they reduce the blood pressure by 5 to 10 millimeters of mercury. And mindfulness, that is your meditation or yoga, that also will reduce. See, you all agree with me that so the reduction of the blood pressure with these activities is much more than your ARBs or the calcium channel blockers or any other drugs. So whether the patient is a combined diabetic and hypertension, so please stress upon the weight loss, good diet, sodium restriction, moderation of the alcohol, good physical activity, and some yoga or meditation. These are very, very important to not to have the complications. Now the question number 8, what are the most suitable choices in the pharmacological management? See, in the management, you all agree with me that the best drugs to be prescribed for the renal cardioprotection is the ARB. See, because the A's are ARBs, so these are the calcium, these are the angiotensin receptor blockers or angiotensin converting enzyme inhibitors. They are not only the antihypertensive medications, they are vasculoprotective, they are renoprotective and cardioprotective. So they protects the heart, they protects the kidneys, they protects the vessels. So that is the reason in all the diabetic individuals with hypertension or without hypertension, with proteinuria or without proteinuria, so the drug to be used is always ARB in type 2 diabetes and ACE in type 1 diabetes. And now we have the combination of the ARB plus diuretic or ARB plus the calcium channel blockers. So you can use all these things, and the step 2, you combine all the 3 drugs that is also available in the Telma trio or Dazzler trio, etc. And in the step 3, if the BP is not under control with this trio, so then you can add the 4th drug, that could be a beta blocker or an alpha blocker or a central acting drug, etc. But there are compelling indications to use the beta blockers like ischemic heart disease or heart failure. So antihypertensive strategy, so start with a dual combination and a triple drug regimen if needed, and uptitrate to the maximum tolerated dosages, and single pill combinations are also available, and once daily morning is the preferable, and according to the thiazides and the chlorothiazide or hydrochlorothiazide, you can reduce the GFR by, according to the GFR you can use these diuretics. So once the GFR is less than the 30, better to go for the loop diuretics like your furosemide or the torsemide. So CCPs are an integral part of the management protocol for the general hypertension and hypertension of the CKD. So CCP, question number 9, which CCP should be a preferable choice and why? So as far as the calcium channel blockers are concerned, we use the 2 drugs very frequently, amlodipine and cilindipine. See, the amlodipine blocks the L type and the cilindipine blocks both the L and the N type. So this is the advantages of the cilindipine. So these are the different generations. In the first generation we use the lipidipine, in the second generation we have the philodipine and minidipine, and the third generation amlodipine and zilindipine, and now the fourth generation the cilindipine. So these are the comparisons, comparison of the amlodipine and the cilindipine. Onset of the action 1 to 2 days in the amlodipine, just 2 hours in the cilindipine, a rapid action. Duration nearly the 30 hours in the amlodipine, 8 hours in the cilindipine. That is the reason cilindipine better to use in the BD dosages. Bioavailability is the lipophilic more. BP reduction efficacy is the good in both the molecules, and edema is less with the cilindipine because it acts both on the L and N type of the channels. And the heart rate is decrease in the cilindipine and increase in the amlodipine. So the people who are on the amlodipine, they will have, it's a big vasodilator, causes tachycardia, perspiration, etc., headache. Proteinuria is increase in the amlodipine and reduced in the cilindipine. It is a more nephroprotective. And the lipids, they reduced in the cilindipine because it acts both on the L and N channels. So if you see these activities, and definitely cilindipine scores over the amlodipine as well as the renoprotection is concerned. So monotherapy or the dual therapy, why and which one to be used? So usually, to the best of our knowledge, so this is the first meta-analysis for exploring the renoprotective effects between the two combination drugs, especially ACE or ARB plus calcium channel blocker, and they compare the ACE or ARB plus the diuretic, and they say that ACE or ARB plus calcium channel blocker is much more better than the ACE or ARB plus diuretics. So this is the different combinations. So questioning the renoprotective role of the L-type calcium channel blockers in chronic kidney disease using the physiological modeling. Switching to L and N-type calcium channel blocker shows the renoprotective effects in patients with a chronic kidney disease. Cilindipine action on the kidneys because it restores the protein and nephrin expression, protects the podocytes, inhibits the oxidative stress, and afferent and deferent arteriolar blockings, thus reduce the glomerular pressure. So intraglomerular pressure will be reduced more with the cilindipine, and it inhibits the renal RAS system. So definitely it reduces the proteinuria also much better when compared to the amlodipine. So more positive effects on the kidneys as far as the cilindipine is concerned. So in high risk patients with the renal disease or the diabetes, so this combination works better in reducing the blood pressures. So cilindipine and ARB offer significant BP reduction in very high risk individuals. So the last question is, what is the newer armamentarium in the renoprotection? So this is the things. See, the phenomenon, that is the new drug entered into the market, that is the steroid sparing mineralocorticoid receptor antagonist. So this acts better because it is a more renoprotective and also the cardioprotective. So in patients with the CKD and the type 2 diabetes, treatment of the phenomenon resulted in the lower risk of CKD progression as well as the cardiovascular events than the placebo. So that is how the phenomenon is making a very good mark as far as the high risk individuals are concerned. So those people who are with the diabetes and hypertension, if you want to use a diuretic, I think the phenomenon is the good drug. So in summary, hypertension in 30%, poor control in 70% of the Indians, the diabetes prevalence is nearly 11%, and still a lack of awareness, young age at onset, and the greater target organ damage like CKD and the CVD and heart failures. Prevention is always better than the cure. BP management is important for prevention of the IH and the CKD. Guidelines recommend the CCB plus ARB as the first line drug. And old generation L-type CCBs do not block the afferent N and the T channels in the kidneys, thus increases the intraglomerular pressure, causing proteinuria, which accelerates the CKD. Cilindipine with ARBs provides the better renoprotection by reducing the more intraglomerular pressure and also reducing the proteinuria, which further slows down the progression of the CKD. And other renoprotective therapies that can be discussed is SGLT2 inhibitors like dapagliflozin and empagliflozin, and the finerenone, that is a steroid sparing mineralocorticoid receptors. So thank you very much for your patient hearing.